Starting off with the eye examination, and now we are done with the inspection of the eyeball or the components of the eyeball. We know the basic terminologies that can be used while we are describing any abnormalities or any diseases that are related to the eyeball. When we are discussing or when we are describing the inspection of the eyeball, it can relate to any diseases or any abnormalities that are present in the eyelids. It can be the superior eyelid or the inferior eyelid, and then we have the canthus openings or the canthal openings. We have the lacrimal duct or the lacrimal apparatus that is present nasally. Any abnormalities or any features of inflammation that can be found on the conjunctiva, on the sclera, or any abnormalities that are present in the iris or in the pupil of the eye. It can be documented while you have inspected the eyeball. You have that patient, he's sitting with you on the slit lamp. You have that particular exposure towards the eyeball, and you have examined or inspected the eye in detail and documented any abnormalities if they are found, and you have basically documented and written them down on your examination or the history taking paper that you have. So now we're going to move on to the visual acuity. If the patient presents to you with the complaints of any range of difficulty in the clarity of the vision, then you are going to examine the visual acuity in this particular patient. So that is what we're going to do in this section. Particularly, we are going to focus on the techniques that are being carried out for conducting the visual acuity in this particular patient that we have. The normal method for demonstrating visual acuity in this particular patient is the Snellen's chart that we have. We have a lot of other charts available as well, known as the 20/20 charts, or it can be the Lord's charts that are available for calculating the visual acuity. But the normally used chart or the normally used technique is the Snellen's chart that is usually devised for these particular patients. The technique over here is to ask the patient to stand at a 6-meter distance and ask them to read out the chart aloud. So these are the particular features of this method that we're going to discuss over here. Then we're going to focus on the Snellen's chart. What are the peculiar features of the Snellen's chart? We'll be discussing them over here. And then the extraocular movements. So the extraocular movements are usually carried out by a group of muscles which include the superior, the inferior, the medial, and the lateral rectus muscles. And then we have the superior oblique muscle, and then we have an inferior oblique muscle. So the nerve innervation to these muscles is the oculomotor nerve, and there is an exception for the superior oblique, and then we have the lateral rectus that is supplied by the abducens nerves, or which is also known as the cranial nerve 6, and then we have the superior oblique that is innervated by the cranial nerve 4, which is also known as the trochlear nerve. So these are the exceptions that we have to remember. One of them is the superior oblique and the other one is the lateral rectus. For the nerve innervations, this is the common method to remember the nerve innervation of the muscles to the extraocular group. So in this section, first of all, moving on to the visual acuity, we're going to discuss the checking of the visual acuity by the Snellen's chart, and then from the proper distance. So make the patient stand at a distance of 6 meters or 20 feet. This is the standard over here. First of all, when you start examining the patient, you're going to make him stand at a distance of 6 meters or 20 feet, in other words. Then you have to check the acuity of the both eyes separately. It's not going to be a binocular vision. Usually the patients are binocularly 6x6, but when you examine the eyes one by one by covering the one of the eye with the help of a card and asking him to read out the Snellen's chart, then you're going to see that he doesn't have a vision of 6x6. But when you remove those cards and ask him or her to read the Snellen's chart, the vision is usually binocularly 6x6. So these are the techniques that can be observed. This is the Snellen's chart that is usually given to the patient for the examination. These letters that are usually used, they're not in an alphabetical order, and these letters are known as the optotypes. You're gonna make the patient stand at a distance of 6 meters or 20 feet, and then you're gonna ask him to start reading this chart from the top. If he comes to this line it's almost a vision of 6 by 6. If he can clearly read without any mistake this line, it's almost a vision of 6 by 6 over here. So this is how we examine the visual acuity in the patients. Then what is the complete method and what are the pros and cons or the prerequisites? We're going to have a look at that. Hold the card approximately 14 inches from the patient's nose. Ask the patient to cover one eye. Read the smallest line and cover the other eye and repeat. It's basically for the near vision that we're talking about. For the distant vision, we have the Snellen's chart, and for the near vision, we have another chart, and basically you cover the eye of the patient and ask him to read the chart, read the smallest line possible from that distance and cover the other eye and then repeat. It's basically for the diagnosis of presbyopia, or we can also call it the near vision abnormalities that are demonstrated in a lot of patients. Then we have the eye muscles and the extraocular movements. So this is the particular features that can be seen. The extraocular movements are controlled by the 4 rectus and the 2 oblique muscles. They're tested by having the patient move the eyes in direction controlled by each muscle, and is accomplished by having the patients move the eyes in the different directions. So as you can see, these are the 6 cardinal positions ranging from here to here. These are the 3 positions, and usually this is carried out by the inferior oblique. This one, when you basically ask the patient to look medially, it is carried out by the medial rectus. And then when you ask him to look medially and inferiorly, it is by the superior oblique. We have the inferior rectus, we have the lateral rectus, and then we have over here we have the superior rectus, which is supplied by the cranial nerve, the 3rd cranial nerve, which is known as the oculomotor nerve. Now, knowing the nerve supply is again very important when we are conducting these tests for the extraocular movements. Any damage to this particular nerve that is supplying these muscles can indicate the damage to that particular cranial nerve. For example, if the movements over here are damaged, it can be any damage that is relating to the 3rd cranial nerve. Over here, if the patient is unable to look laterally, that means the lateral rectus is affected, and that also means indirectly that the trochlear nerve or the 4th cranial nerve is affected over here. So knowing the nerve supply is very important. Knowing the 6 cardinal directions are also very important. These are the 6 cardinal positions of the gaze. Over here, the up and in position, which is usually performed by the inferior oblique. We have the medially looking or the nasally looking position, which is performed by the medial rectus. We have the down and in superior oblique. We have the down and out by the inferior rectus. We have the out by the lateral rectus, and we have the up and out by the superior rectus muscle over here. So these are the normal 6 cardinal positions, and the muscles that are involved in these 6 cardinal positions are again very important. Now, the accommodation is a process by which the eye changes its optical power to maintain a clear image or focus on an object, and its distance varies. And this is the test. It's basically a finger nose test that is carried out for checking out this process of convergence and accommodation in the patients. So in this section, basically we focused on these 3 main examinations: knowingly the visual acuity, the extraocular movements of the eyes, and then the test for the convergence as well. So that is the end of this section. Thank you for watching sqadia.com.